Alright, thanks for coming, everyone. So I think we're going to try to do this more frequently, try to do some more teaching opportunities with your monthly educational stuff. So this is the first one, so give feedback at the end of it, and appreciate you all coming. So this is, I guess, your pulmonary month, and I wanted to talk a little bit about ARDS. This is a talk I gave at the critical care conference, so I'm not going to lie, I haven't looked it over in the last couple of days, so if there's something missing from it, I can talk about it, but the actual presentation itself may not be exactly the way I want it to be. But, so ARDS, first of all, does everyone know what ARDS is and what it stands for? What are those four letters actually? Anyone? Yeah, Acute Respiratory Distress Syndrome. Acute Respiratory Distress Syndrome. And they used to make this big distinction between this and pediatric, but it's really just acute respiratory distress syndrome, and that's what we see a lot up here. So start with that. So this is just going to be an outline of the talk. What is ARDS? What are the causes of ARDS? I'm not just going to be talking about proning. I know that's one of the things you guys are going to be looking at, but I really want to talk about all the different strategies we use to treat ARDS, and so that you guys have an idea of when things come up, what are some of the other options that you can be looking at. And then adjuvant therapies, and then if you guys have any questions, please bring them up. So, acute respiratory distress syndrome, this is kind of the pathophysiology of it. It's an inflammatory response by alveolar cells to a variety of insults. So anything, there's a lot of things that will cause ARDS. And so what actually happens is that there's alveolar capillary leak leading to alveolar filling, which causes shunt. And then you get VQ mismatching due to the buildup of fluid kind of in the dependent parts of lung. So does everyone know the ways that we talk about hypoxemia, shunt versus VQ mismatch? And so shunt basically means your alveoli are filled with something, so the actual air sacs get filled with something. And VQ mismatch, so your VQ is your perfusion versus ventilation. Okay, so the way that in our lungs we have different zones, but we have a pretty consistent way that ventilation and perfusion are matched. So you want to make sure that the parts of the lung that get the most oxygen also get the most blood flow, so that you have a match between those two. And when you have ARDS, those portions, especially these back portions, and when you're laying flat, that's where all your blood goes, because blood does go based upon gravity. You get all the blood flowing into poorly ventilated areas, so you get what's called VQ mismatch. Okay? And that leads to kind of the main thing in ARDS, which is hypoxemia, which just means low oxygen in the blood. All right? And that proteinaceous filling causes a decrease in lung compliance. So if you guys ever hear us when we're rounding, we'll ask about what are the plateau pressures of the lung. Have you heard us ask about that? And so what a plateau pressure is, it's a measure of the compliance of the lung. So it gives us an idea of how severe the ARDS is. So in ARDS, you get very, very non-compliant lungs. And compliance, does everyone understand what compliance means? So if for any given pressure or for any given volume, that will tell you how much the pressure will change in the lung. So when we give a certain tidal volume to that lung, so when we blow up that lung, if it's very non-compliant, that little bit of change in volume will cause a very large change in pressure. And that has been shown to cause damage to alveoli. So that's why we measure these compliance. We look at compliance of the lung very carefully in ARDS. Okay? And then ARDS is not just a lung problem. As we see, patients often will develop multi-system organ failure, and it's basically a systemic inflammatory response, and so that's why these patients have very high mortality. Okay? Any questions about that stuff? Just speak up at any point. You don't have to raise your hand. If anything doesn't sound clear, just speak up. This is very informal. So, the definitions of ARDS. So there used to be an old definition, and this is the more modified definition that came out in about 2013, so out of Berlin, and it's published in JAMA. So the definition of ARDS, and this is why we talk about P to F ratios, is because, does everyone know what P to F is? Or what we talk about when we say P to F? Anyone have a question about that? You can, yeah, sure. So P to F, so the P is this PaO2, which is a measurement off of your blood gas. And your FiO2, that's the dialed in amount of oxygen that the patient is getting. Okay? And so when you take that P, so your PaO2, and divide it by your F, you get these ratios. And normally, does anyone know what a normal, when you're breathing room air right now, what is your P to F ratio?
400?
Yeah, 4 to 500, okay? Because if you take your P, which is your PaO2, what's a normal PaO2 of everyone kind of sitting in this room? No one's on oxygen right now. Alright, so
90s.
90s to 100, right? So just think about 100 is a good way to think about it. So 100 is your PaO2 when just on breathing room air, and your F is about 21%, so 100 divided by 0.21 is about 500 actually, so it's around between 4 or 500. That's a normal P to F, okay? And so this is all based on like your alveolar gas equations and stuff like that, but if you have ARDS, you need higher oxygen to achieve that same PaO2, right? So what you see is that ratio changes, and when your ratio gets below 300, that's when you have ARDS, okay? Any questions about that? No? Okay, so and then what they did in this paper is they found that these different you can break up the severity of ARDS based upon how mild or how severe the oxygenation issue is, and that basically tells you what their mortality risk is based upon that. So some of the things just to know, you can't, a P to F now for ARDS requires you to be on at least a PEEP of 5, so that's part of it. The other thing is you have to have bilateral chest X-ray opacity. So this is just a very, this is actually just an X-ray taken off Google of a patient with ARDS. And then the other thing that was a really big part of this, and has changed a little bit, they used to want to have Swan-Ganz measurements, so measurements of your left ventricular pressures. But now they just say that you can't solely explain this by cardiogenic pulmonary edema. So we see this, you know, you'll see a patient who has very, very bad heart failure, and they can't oxygenate, but they just need to be diuresed. And this is different than that, right? So patients who just need to be diuresed because their oxygenation is poor is different than that, because that's related to mostly cardiogenic pulmonary edema. And then the acute portion of this is just as it started within 7 days of onset. All right, any questions about that? So that's the definition of ARDS. So the three main things, anyone can tell me? What are the three parts of ARDS? P to F ratio? No. Bilateral opacities. Acute onset. Right. And cannot be explained solely by pulmonary edema. Alright? So what are the causes of ARDS? So you guys have been in our unit. So what are some of the things that you've seen that have caused ARDS?
Pulmonary contusion.
Pulmonary contusion. Very good. Infection. Anything else? What's that? The flu, right. It's a flu. So lots of things. Pretty much anything that causes an insult to the lung that can then propagate into a systemic, or sort of a more systemic inflammatory response. So pneumonia for sure, including the flu. Sepsis, just pure sepsis, hypotension. You know, we'll get patients who have severe, oftentimes people are like, oh, they have pneumonia. They don't necessarily have pneumonia on top of a different infection. It's that they had severe sepsis, which has caused them to develop ARDS, and that's really why their oxygenation is so poor. Things like shock, trauma, pulmonary contusions, transfusions. Always remember this. So there's this whole, there's a whole lot of literature about transfusion-related reactions, trolley, things like that cause ARDS, aspiration. This was around Thanksgiving or Halloween, I think that's why it shows that one. Toxins, so there's lots of different toxins that can cause that, and then saltwater drowning is another one. So vent management in ARDS, and this is kind of the hallmark of ARDS management. So when you get a patient who meets criteria for ARDS, the first thing we always tell the respiratory therapist is to do what? LPV. LPV, right? So LPV, what does LPV stand for?
Lung protective ventilation.
Right. Lung protective ventilation is the first intervention in ARDS that ever showed a mortality benefit. Okay? And it's the only one that is universally accepted as improving outcomes in ARDS. So if you have somebody who you believe has ARDS, make sure that you talk to the respiratory therapist, or the respiratory therapist talk to us to make sure that they're on LPV. It's always the start, okay? So vent management in ARDS, first thing you do is you obviously want to treat the underlying cause. Make sure they're on antibiotics if they have an infection. Make sure, you know, anything you can do to reverse that underlying cause. If they're hypotensive, get their blood pressure up, things like that. But just so you know, most patients with moderate to severe ARDS will require mechanical ventilation. And the idea in ARDS is that you put patients on the vent, that are often going to require the vent, and then you basically need their lungs to heal on their own. Alright, because there's not much you can do to reverse the cause of it, but you have to manage them so that you don't cause more, we don't cause more damage to the lungs. And so the idea is this, what they found kind of in the 80s is that ventilatory strategies back in the 80s used to be very, very big tidal volumes to try to improve oxygenation. And that can improve some oxygenation, but it causes what's called ventilator-associated lung injury. That's what VILI stands for. And then what that is that when you stretch the alveoli with very high tidal volumes, you get what's called, you get barotrauma, so you get pressure trauma, and you also get volutrauma, okay? Which is just the size of the alveoli gets bigger and bigger, and it causes this, it basically perpetuates the injury, okay? So what we try to do is maintain this open baby lung, and that's why we use low tidal volumes and high peaks, because what you want to do is you want to make sure that the alveoli don't collapse, because every time an alveoli collapses, it has to reopen. And that causes a shearing stress on the alveoli, which can cause worsening injury. So that's why we use a lot of PEEP, okay? Because you're trying to maintain this open lung portion of it. And this is what you want to do. You want to basically make it so that the alveoli never fully gets to this point, which is the point at which any more volume causes more pressure buildup without any improvement in ventilation. And when you're closing, you don't want it to you don't want all the alveoli to close, because when they close, you get that shearing stress. So you want to keep them with, that's called the open lung model, and just keep them within here, where the alveoli are always open, and just kind of giving a little, you're just ventilating with an open alveoli. All right, that reduces this atelectrauma, barotrauma, and volutrauma. Okay, and that's what the point of LPV is. And what they've shown is that what is LPV? It's about 6 to 8 mils per kg of ideal body weight. All right, that's the tidal volume that you're aiming for. And then using a PEEP ladder based upon your FiO2. So we have one. If you guys want to look at it, it's pretty readily available if you want to see what our PEEP ladder and our FiO2, how those match up. But and this is what they found. This is like I said, this is the first paper that showed a mortality benefit for ARDS, and it was the difference was about 9%. Okay, so the mortality with ARDS is probably around, when before all these new treatments have come up, it was probably about 45 to 50%, and now it's down to about 30% for even severe ARDS. Okay, so any questions about LPV? No? Okay. So something to know, if your patient's so I know I'm kind of giving you guys like, oh yes, they must be on LPV, and that's true, but some of the things you have to correct before that, remember when you give somebody does everyone understand what minute ventilation is? Alright, so what's a minute ventilation?
Tidal volume times respiratory rate.
Right, and what is that, what are you trying to achieve with that minute ventilation? What are we looking at when you do a minute ventilation? CO2? Yeah. So we're trying to make sure that your minute ventilation, you're ventilating enough to actually blow off CO2 and maintain a reasonable acid-base status, right? Patients are very acidemic at baseline, meaning they have their metabolic status won't allow this, because they've either got a very high lactate or they're, whatever reason that they're very acidemic. Putting them on LPV can make that a much worse scenario. So you want to make sure patients are reasonably, their pH is pretty much normal before you start putting them on LPV, because oftentimes their pH will get worse. And we allow a little bit of worsening of your pH. Usually you allow patients to go down to about 7.25 with the LPV, and in severe ARDS with their pHs. But if they're starting at like 7.1 and you put them on LPV, they don't ventilate as well, because you have to put them on their smaller tidal volumes. Like you said, tidal volume is, minute ventilation is tidal volume times respiratory rate. So if you have a smaller tidal volume, and you can only go up to your rates so high before you start trapping, you can't necessarily achieve the same rates of ventilation, okay? And also, sometimes, even with smaller tidal volumes, if you think about it, you have some portion of your tidal volume is made up of dead space ventilation. So the smaller you get, the more you're just using dead space sometimes. So, all right, just keep that in mind. So high or low PEEP, I'm not going to go into this that much. We're not going to do that because we don't really talk about that. So neuromuscular blockade. If anyone has questions about those other things, we can talk about them at the end. But so neuromuscular blockade, you'll see us use this a lot. Neuromuscular blockade improves vent synchrony and chest wall compliance. One thing I want you guys to understand is that when we put somebody on neuromuscular blockade, there's a big trade-off later on, and I think all of us see this in the amount of post-ICU weakness that comes up with this. So this is a big issue for using neuromuscular blockade, and the only actual validated use of this is for about 48 hours. All right, we use it for much longer, and so when patients are on these they're on these paralytics for days or weeks or something like that, there's almost no question that they're going to be severely disabled at the end of this. Okay, so remember, every chance we have to get off the neuromuscular blockade, we should think about that, because oftentimes you need it in the beginning to just try to get patients synchronized with the vent, and then oftentimes we can wean off of that and just keep them well sedated. So I think that's when we round on these patients, think about that. Think about, is it time to get off the neuromuscular blockade? Because if it's not, it doesn't always add much to it if you can sedate them appropriately. Okay? And then the one that's been that they used in the trials was cisatracurium. And that's a non-steroidal based one, and that one caused a little bit less weakness or a little different, a little less muscle weakness than some of the other steroid-based ones like vecuronium or rocuronium, but it's also pretty expensive. So once again, 48 hours was kind of the maximum time. All right, any questions about that? All right. There's supposed to be a question there. All right. So proning. So this is what we have chosen as our kind of major intervention for patients with severe ARDS. And so, what are the effects of proning? These have been shown to be true for many years. They started proning people back in the 70s. So improves oxygenation by shifting the weight of the heart onto the less lungs, so more recruitable lungs. So this improves VQ mismatch, kind of what we were talking about. And then it decreases lung injury by showing better, it causes less deep recruitment, less atalic trauma, and you get more uniform ventilation. So that's why we do it. So it's physiologically shown to improve oxygenation. And then there are good studies, especially the one that came out in 2013, which shows that there's a mortality benefit to proning patients early. And so these are very significant numbers. I'm not sure that we see that significant of an effect, but in these trials it was quite significant. And then they've also done multiple meta-analyses that show that proning is beneficial. Okay? And so when do we prone patients? Patients who have severe to moderate, or moderate to severe ARDS. So this is based on that P to F ratio we were talking about again. P to F less than 150 on a very specific vent setting, 60%, and 10 to PEEP. This is what the trial shows is beneficial. And this is where we kind of made a shift, where proning used to be only for rescue therapy, whereas now we prone for even kind of moderate ARDS patients who are statting okay on reasonable vent settings. But the data does support that this improves overall mortality. And I think you'll see it actually decreases vent days and stuff like that, is what we've seen as well. And then as long as they have no contraindications to proning, these extremes have height, weight, increased ICP is a big one, surgical issues, or unstable fractures. Okay? Questions about that? And then when do we stop proning? We want to keep the patients in the prone position for as much of the day as possible. Greater than 70% is the goal. You don't have to be on a bed to prone. We've started manual proning. I think it's worked pretty well. On the right patients, we can manually prone, and I think that's probably better because it actually makes you guys think less about having to flip the bed over and check everything. So you can actually keep a patient in the prone position for much longer when they're manually prone, because I think it's just it takes more time to flip them so they stay the way they're supposed to for longer. And then when you get improvements in oxygenation, so that's when you really can stop proning. When your PDAF is greater than 150 on 60% in 10 of PEEP while supine for 4 hours. And this is where I think we keep getting questions about this. So patients don't need to, if they're not tolerating these vent settings while in the prone while supine, there's no point in keeping them for 4 hours there. Just reflip them. All right. So if they're at 60 and 10 and they're statting 88%, there's no way their PDAF is going to be greater than 150 on that. So just flip them back over after you've done whatever you need to do with them. There's no point in letting them sit there for 4 hours, okay? That's the true protocol, all right? So I mean, that's what we would like to aim for, because what ends up happening for us is that they're sitting there, they're at 70 and 10, and then there are people like, oh, they're statting fine on 70 and 10, let's just leave them for 4 hours, and then that doesn't really match what we're trying to do. We really want to get them at that level with that PDAF, okay? So if they're statting 100% on 60 and 10, get your gas after 4 hours. If their PDAF is better than 150, you can stop proning them at that point, okay? And then unacceptable skin breakdown, and then just intolerance of prone positioning, okay? Those are the reasons to stop. Questions on that? All right, that's it. She's much older than that now. All right. Any questions?
I had Brittany couldn't come tonight. She said trying to get a hold of the PEEP ladder has been really. Where do we find that, or?
There are published PEEP ladders. We have a separate PEEP ladder. We have a high and a low PEEP ladder, and I don't think so. The RTs all have the PEEP ladders, and they run off of them. You know, can you grab Pete or Tsugumi out there real quick?
I can get a copy of it as well.
Yeah.
Okay, yeah, Brittany said she's.
Just to look at it?
Yeah, and to have it there.
Yeah, I mean, so the RTs are supposed to, they will follow the PEEP ladder and go up and down on it. I mean, if you have questions about where they're at on the PEEP ladder, I'd ask the RTs. Where do you guys have like a PEEP ladder form?
Yeah, we just use the ARDS In one.
Yeah, like I said, there's a couple different ones. There's
I think Alaska has a different one, and so like the order set that comes up is from Alaska, and it is not the one that we abide by.
Yeah.
So we have some back in our blood gas lab. If you want a copy of it, just ask.
Maybe I can get it from you and then before it's nursing.
And so, I mean, we have two separate PEEP ladders that we can order. There's a low PEEP and a high PEEP. So there's been some studies that higher PEEPs maintain, in different patients, you need a different PEEP ladder because mostly based upon transpulmonary pressure differences. But for us, we typically just use the same PEEP ladder on everybody. So if you want a copy, just ask the RTs.
And then her other question was, and I don't know if we've had this situation, but as an exclusion for the rotabed, have we ever had that time when somebody's been on the intercool? And I don't know why she was asking, you know.
I mean, it's not necessarily.
I'm sorry, is Intercool like Arctic Sun, does it have pads?
No, it's the intravascular, yeah.
Oh, you should still be able to do that because you can do dialysis with a
Right, this
thermal
is a bigger
catheter.
catheter, that's why she was concerned.
No, I think it's, there's no
Still
inner,
okay, okay.
it's fine.
You just have to put your proning pack up a little higher so that it's not really pressing down on that area.
Okay.
So yeah, I think that's, we do it all, you can do a lot when you're prone. You know, if you talk to the Denver people, they do all sorts, they'll prone anybody with anything in, so. We're a little less aggressive than them.
About trachs?
What's that? Trachs, yep, we do trachs, we've trached people who've been prone before, that's not an issue. It's as long as they require if they require that ventilation, like I said, the main contraindications are the increase in ICP, or surgical issues that are going to cause them not to be able to tolerate it. Open belly, that's probably a bad person to prone. I mean, we've prone a pregnant woman before. Plenty of people have prone pregnant women. There's not a lot of contraindications, but there are some. All right, and the extremes of height and weight are for the bed. They're not necessarily for manual proning. So there's patients that you can prone that don't fit on the rotoprone bed, but you could still prone them if you had to. All right. Anything else? Any questions about ARDS in general? Yeah.
Well, I had a question about, you were talking about paralytics with dysynchrony, and I wondered, if you ever use dantrolene with any effect, or if it's not really strong enough
Dantrolene as a,
as like as a short-term, like, poor man's paralytic to try to get synchrony instead
well,
of
we're not
fully
really poor
paralytic?
here in this country, so
Yeah.
we've used the there's
Well-
like, dantrolene's not really a paralytic in the end, right? So what do you use dantrolene for?
Shivering?
I mean, typically, the main use of dantrolene is for something like a malignant hyperthermia.
Okay.
You know, it's a calcium channel. It works on calcium channel. I have to think back to this. So it may provide some degree of muscle relaxation, but it's not a paralytic.
So it's not gonna help?
It's not considered a paralytic.
Okay.
And I mean, or like I said, if you can get dantrolene, you can get VEC, you can get ROC, and you can get cystatin. So use one of those
Yeah.
instead.
I meant it in the sense of like, instead of going to a full drip where you like causing so much more morbidity, you know, with weakness and everything.
So I would say in that case, use
Just
one.
try it
Well, so we
first.
do this sometimes, right? You've seen us say, just
You
give
just
them
go
50 of rock,
Yeah,
and
see
just
if
see,
it
just
helps.
get them synchronized,
Yeah.
and then keep them well sedated after
Mhm.
that. And that's a better. I mean, that's a true paralytic that you can get good bend synchrony with, and yeah, because I would not. You know, dantrolene is, first of all, it's a pain to mix up. I don't know if you've ever had to mix up dantrolene.
I have not.
Yes, so these are things that you don't want to use dantrolene.
Okay.
Just leave it out of there.
Okay.
Alright. And I mean, the other things that you guys will hear about are things like, you know, inhaled nitric on patients. I mean, have you seen ARDS patients been put on nitric? It's not proven to be helpful, alright? So inhaled nitric is actually been shown to worsen renal outcomes in meta-analyses, but the bigger point is that it doesn't actually change any outcome except in patients who have refractory hypoxemia. So if you've done everything you can and you can't oxygenate them and they're oxygenating in like the 60s, you can start them on inhaled nitric. But I wouldn't do it unless that's the case, and you should get it off as soon as you can use some other form of improved ventilatory some other ventilatory strategy at all. All right. The other thing we've also transferred a couple patients for ECMO. ECMO is kind of an emerging therapy for ARDS. We're not going to do it here, but we have the ability to transfer people. So if you find that there's, you know, we've proned them, they're on maximal therapy, 100%, 20 of PEEP, we're not getting anywhere with these patients, you can always suggest maybe ECMO as a thought, all right? And they're doing ECMO down at the down at Harborview, they're doing it at Swedish, they're doing it at Bellingham, and they're doing it down in
What is ECMO?
Oregon. Extracorporeal membrane oxygenation, so it's bypass, it's lung bypass basically. Put in big catheters and you just run it through a bypass machine. So, and that allows, we don't do high frequency oscillatory ventilation here, and nobody really believes in that anymore in terms for adults, better for kids but not for adults. That's about it. Alright,
Thank you.
questions? Alright,